everybody in this room has some sense and knows exactly what you should go back and do in your system. You understand the pillars, you understand your systems of care, and you know what you need to do in your system. Yes? The how is something that we really have somewhat overlooked for a really long time. And it's something that I think has been missing in all of the work we're doing. Because when we just put things out into our systems and we don't tell the system how we're going to go about doing that and navigating it, you don't get to the place you want to get where it sticks. So we talk a lot within our system about how do we make this a permanent tattoo and not a temporary tattoo. And if anybody wants to go later and get a tattoo, Brian will be glad to accompany you and get some kind of tattoo. Yes? Okay. So it's the what and the how. It's both, and we should spend some time thinking about that. So I'll speak a little bit about, I live in the South. I live in Nashville, Tennessee. Anybody ever been? Yes, country music and Jack Daniels and cowboy hats and bachelorette parties is what we're known for. But I work in a system that is based out of Nashville, Tennessee. We're a multi-state operation. We have very large pieces of our company are in multiple states. And so we decided in 2012, so well over a decade ago, that we were going to take on suicide prevention in a different way. And our company was looking at developing clinical pathways for a variety of disorders, depression, bipolar disorder, schizophrenia, substance use disorders, and nobody really had thought about suicide prevention. And as they were talking about this, as I sat in a meeting, I knew none of that had anything to do with me, so I was checking email. And then finally, as an afterthought, someone said, well, gosh, we should do one for suicide prevention. Wonder who should spearhead that. And I was head down typing, and somebody said, well, you are over crisis services, you should spearhead this. And I thought this would be a very time-limited process. I kind of approached it as a paper I had to do in an educational setting, and I would do that and turn it in and move on about my business. And it really didn't unfold that way in our system. So in 2013, we had gone and we went to the internet and we said, is there any kind of system that Hardy has done this? We didn't find a whole lot. There was not a zero suicide package at that time that we could take off of the shelf and just implement into our system. So we went about figuring out what we thought the system should look like, and we piloted that in our Tennessee operations. And then we subsequently implemented it across a very large array of services. We're what's known in the U.S. as a community mental health center. So that means you have medication and therapy and school-based services and foster care and residential programs and day treatment. I mean, it really runs the gamut. And then we had another state join our system in Indiana, and we piloted and implemented some of this work there. Over the years, more states joined our company, and we really had not figured out or packaged how we were going to introduce suicide prevention into those additional states. So we spent time over the past few years trying to calibrate and make sure all of the things that we're doing across the system. So if you walk into our location in one state, you should get the same suicide prevention care as the next. So currently we're operating under a federal grant that is allowing us to look at a 2.0 version of our operations, and we're also making sure that we're calibrated across the system, and that it almost looks like a fast food restaurant, but if you own a Burger King or a Wendy's or a McDonald's or a Chick-fil-A, or even I saw a Hooters, Liverpool, you have a Hooters, that it looks the same everywhere you go in and it tastes the same. So we're trying to make sure we do that. But what really became evident to us as we wrote our application for this federal money was that we had spent a lot of time telling our folks that work in our system what to do, but we had not spent any time about how to do that. So we hired an implementation scientist, and we framed this as kind of a relaunch or a polishing up of what we had been doing for over a decade. And so I coined it that we were renewing our wedding vows, so to speak. And that's how we presented it to the staff, that we've been doing this for a long time. We've had good success. We've had bumps in the road, but that it was time to recommit and double down on this. So we hire our implementation scientists. I'd never heard of that position being something that would be helpful to the system, but we are fortunate that we have a research institute at our company, and so they set about hiring an implementation science individual for us. So I got educated pretty quickly on what implementation science is and what they were going to bring to the table for us. So they schooled me a lot as the project director for our grant. So what they said to me is there's a lot of reliance on these kind of traditional things that we do when we want to implement something new into the system, and you see those here. So we tell people about it, we mandate that they have to do it, we roll out training, and we educate the staff on that. And they said to me, you need to stop training and praying. Like you train and then you just pray it goes okay. And so that was a mantra they constantly threw at me, stop training and praying. Because when we do these things, and this is the method in which we do it, you don't really get the outcomes you're looking for. They don't work, and if this is the only way that you do them, because we're employing these methods to solve problems that they really were not designed to solve. And so we have embraced implementation science in the work we're doing with this kind of 2.0 version. And I will tell you, if you take nothing away from what I say, and I'm very cognizant we're right before lunch, so we'll end right on time. But if you take nothing away, take away this phrase that they constantly were saying to me and continue to say to this day. And I don't know if it translates into other countries, but if it doesn't, I'll explain it. You have to till the soil. And what they meant by that, and they harped on this with us, is get out in front of whatever it is you're trying to blast into the system and get the system ready for it before you do that. And they would say to me, measure twice and cut once. So if you get out in front of this and you do all of the work that you need to do before you're going to implement it, it'll stick. It'll be tacky, and it will take hold, and you won't have to loop around again to redo some of these things because you went about it in a poor way. And so we've really tried to embrace that and make that part of the culture, that we don't think about these initiatives and all these things folks are going to get up here and talk about and have spoke about this morning without employing some of that. So we also wanted to make sure that a big part of this was co-creation, that people don't like having things done to them, they like to be a part of, and that we're doing it with them. So all of the individuals that work in your system, think about that we're not doing things to them, but instead we are trying to do things with them so that they have some sense of ownership in the process. And do they even believe in what it is that you're trying to get done? So you do want to tap into what their feelings are about the initiative. So this kind of social and emotional impacts of change. Anybody in here a social worker? Me too. Some of them, I don't know in your country, but in ours, and I can say this because I am one, and sometimes it's social workers that are a little bit older, they're cranky and crabby, and they're and so when you approach them and you talk about, we're going to do all these things for suicide prevention, they're like, don't need it. I intuitively know if somebody's suicidal. So you have some work to do there. If you roll this out and you don't have their buy-in, the patients they're seeing, it's not going to work. And what we have discovered in our system for sure is if you present people coming into your system to work with, guess what, we're going to do all of these things and this is how we do it. But they get to the location where they work and either they see it's not being done or people blatantly tell them, we don't really do it that way. If you don't acculturate that, you're dead in the water. Dead in the water. I bartended when I was in undergraduate school, which was like working in the mental health field. It was my first, I guess, job in mental health, working as a bartender. And they told me you can't eat behind the bar. Like, that's not allowed. You cannot eat. Probably within the first week, I learned by watching, if we sent beer to the kitchen, they sent us cheese sticks. And you put the cheese sticks underneath where the dishes go, and you could lean down, and you could eat cheese sticks at the bar. So they told me we couldn't eat at the bar. It was drilled into us. You cannot do that. It's against code. And within the first week, if I sent a beer back to the kitchen, I could get some chicken wings or some cheese sticks sent up to me, and I could eat them underneath the thing. That it didn't, that's the way it was. And it was the way it was the whole time I was there. And I often think about that. They told me things that really were not the way it was. So we want to acknowledge how all of our staffs are feeling about this. This is dangerous work, and I don't really think we've ever framed this work as dangerous. But it's dangerous for the people in our care, and it is dangerous for our staff. So we have to make sure we understand how they feel about things like this. We get nosy in our system, and we like to look at data. So our chief quality officer, one day, because he was curious, ran a report for an entire year of data that showed how often each of our individual staff had positive PHQ outcomes. So in the first column was all the staff's name, and this was thousands of clinicians, thousands. First column was their name. The second column was how many times they had given a PHQ screening, not even an assessment, a screening in a year, 1 year. And the third column was how many times they are positive screens. And then the fourth column was the percentage of time. This is in a community mental health center. Thousands of people are coming through the door daily. We had a handful of staff, not a bajillion and not 2 or 3. We had a handful of staff that worked in a community mental health center, and in the 1 year period that we looked at, had 0 positive screens. There's just simply no way that's true. And so in our old system, I wouldn't have gone and beat them up, but that would have been very concerning in the sense that we probably would have been very directive about. So we would probably used a little bit more vinegar than honey. But implementation science said to me, no, slow down, and let's just go talk to them. And we were like, well, that's a novel idea. Like, go speak to the people that had 0 positive screens and ask them why. So we did. And we went and did a focus group with the people that had the 0 positive screens. And we thought they were going to say it's too time consuming. I don't think it's important. I know if they're suicidal, I don't need this. We already had preconceived notions about it. Not at all what they said. What they said was, when I was in school, I learned to build rapport before you talk about heavy topics like this. And I don't feel like in these early visits, saying something that intrusive allows me to build rapport. It feels counterintuitive. And one of the direct quotes from the focus group, a clinician said, I feel like I'm saying, hi, my name's Brian. Do you have an STD? That was a quote, a direct quote from the focus group. And we were like, okay, we can fix that. We can fix that. So we went about developing training that I dubbed teaching them how to be cool. I said, we have to teach them how to be cool, because what they're trying to do, which is build rapport, can be done in the framework of what we're trying to get them done. And so this kind of teaching people how to be cool became something that we could roll out so that they really did understand having this conversation could help them in the rapport building. That is not what we would have done prior to implementing this kind of a framework. I think we would have not been heavy-handed about it, but we would have gone about it in a different way. You also have to address any past wrongs. If you've rolled out an implementation of something and it has not gone well, or people have been, punished, or things that are negative, you do have to address that. So we want to prioritize these two things. How great does the staff think this thing you're doing is? Do they buy into suicide prevention? Do they think 0 is attainable? Do they understand what it is you're trying? And they give it a thumbs up. And the second, and probably the more important thing is, do they think you're going to show up? Are you going to support them in this? Are you going to give them the time it takes to train? Are you going to give them the time it takes to do safety planning and all of that stuff? Are you going to do that, and do they have confidence that you're going to be there for them? So to do implementation science well, and to make sure you're implementing this, what we have heard over and over again is slow down to go faster. Because what will happen is, if you can slow down and get it right the first time, this measuring twice and cutting once mentality, if you can slow down, you save yourself a lot of time. And so you want to look at these kind of 5 buckets that really are the basis of how to implement implementation science. So you want to have co-creation partners. Ask them, speak with them, do focus groups. Make sure everybody understands what it is you're trying to do. And that your teams that are working on this are twofold. That you do have a leadership team and people that are over the operations of it, but that you also have a separate group really dealing with the implementation piece. I have the work groups that we're operating off of and have been for a couple of years to the side here, and you guys can see those. But we have very specific people in those groups to make sure we're covering, that we're developing the workforce, and that we're not asking them to do this kind of work without the tools they need to do it. And we have really mandated in our system, you do not speak of training unless you speak of supervision. That it's really peanut butter and jelly, champagne and orange juice, I don't care what you call it, but you don't have one without the other. And if you train individuals and you do not provide them the supervision they need and the time for supervision, it never works. And so this workforce development needs to be co-occurring with training and supervision. Being curious about data. We never would have known that we had hands full of staff having no positive screens unless somebody had been curious and nosy and gone in and looked at the data system. And then continuously feeding this back to the staff. When we renewed our vows, we're like, well, I can send an email out and, make it kind of short so people don't get bored with it and not read it. But we decided instead, and I'm glad to share this if anybody wants to see it, one of our individuals working on this is very creative, and she went to a craft store and bought construction paper, and she cut out people and made a stop motion video. And she did it on her kitchen table. It cost really the cost of a pack of paper is what the money amount was. And she just would watch television and cut out these people, and she laid them on her table, and then she overdubbed it and made this stop motion video. And we sent that out to the staff talking about the renewal of our vows. We also videotaped some of our clinicians that do a really good job in our pathway with some individuals who had been in our suicide pathway a couple of years prior and were doing very well. And we videotaped them for about an hour, and then we asked them specific questions, so that we could cut that video into little bites. And so we implemented that, and it was just a better way to communicate with, and the staff really enjoyed that. We did infographics instead of just sending out emails. The last thing I'll tell you, there was a lot of talk about safety planning. And one of the things that when we actually took time to go out and talk to the staff and hear from them about things that they felt like can make our pathway better, one of the things we worry about is fidelity of safety plans. It's such a big part of what we do. It's such an important piece of what we do. And we heard from a good number of individuals about not really having the skill set that they wanted to have around safety planning. So this also costs very little money. But we piloted and we're implementing a program where the clinician can sit with the individual to do a safety plan. And when you get to the very beginning, you can click on a micro video. And it's about 30 to 45 seconds. And it's someone in our research institute going, "Hi, my name is Jennifer, and I'm going to tell you about what safety plans are." It's about 30 to 45 seconds. Boom. Okay, we ready? We're going to do it. They get to the first section, which I think is warning signs maybe. And then the video, you can click on the next video. It's about 30 to 45 seconds. "Hi, it's Jennifer again. The first section we're going to fill out is around warning signs. Let me tell you about why that's important. And what I want you to think about as you fill this out with your therapist around what you would want to do." There's a micro video for every section of the Stanley Brown. And our hope was that we would get what we would call a twofer. Is that Liverpool language, twofer? I've heard a lot of Liverpool things about a half lamb, or a lamb and a banana. That's a twofer, right? But what you hope is every time the staff uses that, they're being trained. And if they want to continue to use those videos, they can continue to use those videos as long as they want, because they're being trained as they're using it. And then if they get to the point, or when they get to the point that they no longer want to use the videos, then they know what to say because they've heard it over and over and over again as they're filling out safety plans with their patients. So that's been something that we've been able to use some of the federal dollars that we've had, is to try to, think outside of the box and be innovative and address some of these issues that we know come up around things like safety planning. So I just encourage you all to think about implementation science, look it up, get to know an implementation scientist, because I don't think we're at a place where we can continue to just talk about the what without having to talk about the why. So thank you.